Justin Yanati wants to press commission.
Okay.
Just give me a heads up, we finally finished the 19th check. But there are several documents that are expiring to like 11/20.
I think the cameras are on. Another new 800 portal radios.
Who about the projectors? Are they get down there?
Yeah, but
I don't think they
I don't think they do.
do.
Few new 80s.
Like to call the November meeting of the Indiana EMS Commission to order. And with that, we have some announcements regarding positions.
Announcement before we do roll call vote, because become evident during roll call vote. As you know, Jonathan Whittam is our Executive Director for Homeland Security now, and the position for Homeland Security is either the director or a designee. And he has indicated with his schedule that he appreciates the EMS Commission and wants to contribute, but will not likely be attending. With discussion between he and I, we have discussed and he is designating Dr. Eric Yazel as the IDHS representative. So he will be the actual designee, which means he will be a voting member. So I wanted to announce that before roll call. Thank you.
If we could please call the roll.
Sorry, that roll call.
Yes.
Okay. Lee Turpin,
Here.
Darren Haggett,
Here.
Dr. Lisa Whiting.
Good.
Here. Patrick Hutchinson.
Here.
Matthew Shady,
Here.
Jerry Harder,
Here.
John Zartman,
Here.
Dr. Sarah Brown. Here. Matthew McCullough.
Here.
Andrew Bowman,
Here.
Mary Ann Dudley. Here. Dr. Jim Nossett,
Here.
Lori Maley. Here. And Dr. Eric Yazel.
Here.
We have a forum?
Yep.
Do we have anyone call online? I don't believe
One.
one. Okay, so we will need to do all votes as roll call. Okay, that's it. Yeah, we can, then we'll do what the. Pledge
Allegiance to the flag of the United States of America and to the republic which stands one nation under God, indivisible, with liberty and justice for all.
Just like to welcome everyone here to the Crossroads EMS Conference. It's a joint venture between the Emergency Nurse Association and the Indiana EMS Association. We believe this is probably the largest one we've had yet, so invite everyone. If you're not staying over the conference, we would invite you to consider staying at the conference and thank them for the facilities they've provided today. With that, moving into the agenda. We'll move ahead with adoption of minutes. Pleasure of the commission. Motion approved. Second. Motion approved. And second on the table. Any discussion in the minutes? We can have a roll call vote for approval.
Lee Turpin,
Aye.
Darren Haggett. Aye. Dr. Lisa Clooney. Aye. Patrick Hutchinson,
Aye.
Matthew Shady,
Aye.
Jerry Harder,
Aye.
John Zartman,
Aye.
Dr. Brown. Aye. Matthew McCullough,
Aye.
Andrew Bowman,
Aye.
Mary Ann Dudley. Aye. Dr. Nossett,
Aye.
Lori Maley. Aye. And Dr. Yazel.
Aye.
Minutes have been approved. Moving on to honorary certificates.
See, we have a number of the usual honorary certificates. I did issue one state EMS Director's Award to Burton Rankin. And then we did have, unfortunately, since our last meeting, as most of you know, we had the passing of Bob Miller from the EMS Association. He was a line of duty death October 9th, 2025. I did attend and spoke at his memorial service in Indianapolis. And we did give him the usual line of duty death designations, which include the flag case and the Star of Life plaque. We did also issue a paramedic emeritus due to his strong contributions to the EMS profession as an advocate and also this particular conference. And so that was probably our biggest honorary designation.
All right, any comments? Hearing none, we'll move into reports. Indiana Department of Health.
I believe Vince is online for that.
Yes, sir. Thanks everyone for having me today. And sorry, I wish I could be there with you, but hoping to get Brian down there to attend. So we'll get some feedback from him as well. So you can move to next slide, please. Again, I'd like to, all our slideshows, we always like to include our mission and vision. Basically just what we're all here to do is promote, protect, and improve the health and safety of all Hoosiers. You can go to next slide. The next two slides, I don't want to spend a ton of time on unless folks really need you. I'm sure you'll get the slideshow, but I want to talk a little bit about the Rural Health Transformation Program grant that's being put in. So I imagine most folks there are aware of this. This is just more background, but just for some kind of key updates, key figures on it, the government is looking to designate $50 billion to the states, and it's over a 5-year period. We had an application deadline that was due November 5th that we weren't even notified until I feel like it was some point in September. So it was a quick turnaround. Next slide, please. So these are the 5 areas that the grant kind of outlines and what you need to work towards. And I'll show you on the next slide the areas that we attacked. So one of the main things that we've been hearing a lot about is having a medical operations center, looking to change some connections through the 211, all these different things you'll see pop up. And I apologize, they're going faster than I thought I set it for. But some of the main things I want to make sure this group's aware of is the mock. That's really one of the big pushes that we've been looking to do through trauma and in collaboration with other like Department of Emergency Preparedness and Homeland Security. So that one and our pediatric readiness kind of across the rural emergency departments are big ones, but all these are initiatives that were submitted on the grant, and it's not up right now, but FSSA will be releasing kind of the overall grant once they're able to, and the link is there in your on the slide. So I do encourage, if you want some more information to see what the actual grant looked like, please feel free to check that out. I don't have an exact date, and I was actually just on an all-staff meeting with Dr. Weaver across for the whole Department of Health, and there wasn't an exact date given yet, but it will, as soon as we're able to, it'll be shared. And just briefly on the Operations Coordination Center, originally you may have heard some discussions around like regionalizing it, and right now the way it's set up is we're looking to do a statewide mock, so like an SMOC, if you will, or just calling it mock, and then based on need and kind of how it evolves, we may end up breaking it down into regions or having some kind of regional component. So I just want to be clear, because I think maybe as some of the earlier discussions, we used the terminology RMOC a lot. And so for this instance of what we're looking to do and through the grant, it's really going to be getting it set up from like a statewide perspective. Is there any questions on this before I go to the next topic? Okay, hearing none. Oh, all right, thank you. Next slide then. So I just want to make everyone aware that this, the Trauma Care Commission's annual report has been sent to legislation. These are some key takeaways. This is important, and I want folks in this particular commission and the group that are supporting it to understand, when we look about midway through, we'll see greater than 1,600 statewide healthcare professionals access training education, and where it says greater than 160 rural healthcare professionals received high fidelity simulation training. A lot of those folks were EMS. So we're really happy to support that and make sure that folks are aware that we continue to support EMS through different venues with training and education as well, knowing that it's a key part to the success for a statewide trauma plan. I will also put a plug in for anyone that sees any of these RIC events, so the Rural Health Innovation Collaborative. Those are free. They happen at smaller hospitals, oftentimes critical access. So, but they're free. You just have to register so we have a head count. But that's where a lot of our EMS partners have been able to take part in that high fidelity simulation. It happens at a hospital, but it's open to anybody that will travel to that facility, even if it's if you happen to be someone who's off that day and you want to travel a little further to maybe an area you don't typically support, you're still more than welcome. Any of the staff are more than welcome to go and participate at these RIC events. And all those are listed on our website under our educational opportunities. So again, if anyone has any problems finding that, feel free to reach out to me and I'm happy to get you directed in that way. So some of the other key highlights, we have a statewide performance improvement plan that was adopted by the Trauma Care Commission. You'll hear a little bit more about that here in a moment. Continue to support process system developments, and we have more than 6,500 prevention services have been offered through various grants and pieces of that work. So screening assessments, preparedness, supplies, safety modifications to folks for falls prevention, and all the whole gamut. And I guess another thing, because I know a lot of the folks here participate on the track meetings that we have quarterly, and we encourage everyone, please do and be a part of those. But we're looking to put together really some kind of overarching governance to it, and in the form of like a 501c3 that may help kind of take it to the next level. So we're exploring some of those things through different tracks or subcommittees rather. And I'll talk a little bit more about that on the next slide, and you can go ahead to the next. Okay, knowing you guys are busy and you're at French Lick and you got other things you want to move on to, I don't want to take too long. So I put all our subcommittees on one slide, just picked some of the highlights that's going on. So registrar course, there's going to be a free training course. It's being in development right now. That should be ready by the end of 2025. We did a statewide trauma kind of report through the registry, and really kind of nothing crazy arose of that. Falls continued to be the #1 traumatic event across the state and for all ages. So performance improvement subcommittee, I talked a little bit about the statewide PI plan. So great group of guys chair that subcommittee, really fond of them. Focus on triage and delays and transfer indicators aligned with statewide track funding. So again, we're just taking the data that we kind of get with registry, putting it together through the performance improvement outline of the plan that we put in together, along with some performance indicators. So really the measures, and then we're going to ultimately, once we get some data back on that, we're going to start tying that into tracks and how tracks can then move the needle to, either increase or decrease, or whatever it is we're looking to do, right? Kind of depends on the benchmark. But ton of good work's been happening with all these subcommittees lately. Disaster preparedness and military integration, kind of some of the big things. We're really building, working towards building a TAA, a training affiliation agreement, so that military medics can work in our civilian facilities. A lot of these folks aren't healthcare workers, and they're kind of 9 to 5 daily jobs, but when they're in reserve, Air National Guard or Army National Guard, they're medics. So one way for them to keep their skills up is to be able to work in hospitals and other settings that they can and continue to flex that muscle. So we're working on that. It will actually be the first in the country to have a statewide plan if we get this to go through. So it's pretty exciting. We're on the kind of the forefront. We've been talking with different branches, and more to come on that. I hope to have some good news and following commission updates for you guys. Looking to put together a mass casualty kind of disaster exercise. So this timetable that's on your slide is a little tentative. So obviously there's going to be a planning phase, and then we want to do a tabletop and then a live exercise. And a lot of that stuff is in the works, and it's incorporating some different districts. And ultimately, as we get some more kind of pen to paper, the idea is that this will reach really statewide for folks that are willing to participate or to want to hear more about it. So really excited about that. So we're bringing together some HCCs, and we're bringing together some subcommittees and just trying to line things up so that we can have a good event. Education and outreach. So one of the things some folks may be interested here to learn is that we're looking to build an interactive map. So right now, um, there's a ton of great work happening across the state, but not everybody knows where and who's doing what. So we want to try to catalog those as best we can, really starting with hospitals, LHDs, EMS, anybody that was willing to share that information, really kind of a large scale, someone who's vetted. So we're not doing the one-off 501c3s yet, but looking at the broader things that we know are kind of vetted and proven. So we're looking to do that where you'll be able to click on a map, hit your county and see what's going on. And then various informations could be bicycle helmet, could be falls prevention, could be your firearm safety, whatever it might be. I'm still trying to work and get that built, so more to come on that, but it's in the process of moving forward. And then just looking, I know a lot of folks from EMS participated in our last statewide trauma symposium. And so we're just kind of looking at that, seeing what's most feasible. We know there's a lot of them that go on throughout the state. So is this something that we're going to do every other year or continue to do it every year? And if anybody here has any feedback on that, we're happy to hear it. You can share it with me. You can share it at a track meeting, whatever. We just want to make sure that one, we're doing what folks find valuable, and two, that we're being good stewards of the funding that's been provided to us. So that's going on. And then trauma system planning, really just looking at how we could implement a level 4 trauma designation based on ACS criteria. Now, we'll be clear, that is not out yet. ACS is still working on that on their end. And traditionally, we follow suit with ACS right now from a state designation perspective. So, but we know it's on the horizon. So we have it in the forefront just to kind of, put a pin in it, and we'll continue to follow with what ACS is doing. Next slide, please. And I just want to give a couple quick updates for your tracks. So all the tracks are really going to be looking to boost non-trauma center involvement. And one of the ways we may be able to help do that is through some of this RHTP regional grants. So like I said, we won't know. We'll know December 31st if what the grant is, what we're getting, and how much is going to be awarded. So work is still going to move forward. We do anticipate that we will get at minimum half of what's being offered out, but it could be up to 200 million per year for 5 years to work on all those initiatives I showed earlier. I'm sorry if I didn't share that number earlier when we were on the slide, but so that may be a way. And then more specifically within your North track, looking at case reviews, trauma protocol development with non-trauma centers, and then opportunities for RTTDC to kind of pick back up. We know that there was a pretty good drop off during COVID, and it just hasn't picked back up to the same swing and kind of speed that it used to be. So that's something the North Track leadership is working on. Your Central Track continues to recruit for some physician involvement in their leadership roles. So if you know anybody that falls within emergency preparedness districts 4, 5, 6, 7, and is a physician and fellow, we support a fellow as well. We may have some opportunity to get them on either the advisory board or the leadership to leadership level. And then your Southern track, looking at some different injury prevention strategies around agriculture and motor vehicle mechanisms, and also to expand engagement within that track beyond just District 10. So I'm just trying to get some more folks from Districts 8 and 9. So if anybody's familiar with Dr. Welsh, he's over at Margaret Mary in District 9, and he's joined the leadership team down there. So we're starting to grab out a little more, but just for anyone that may be in those districts 8, 9, and 10, please be a part of your track and give us whatever questions you got and or information that you want to share. So we're trying to make these usable, helpful meetings for not just trauma centers, for anyone that's in the trauma related space. So that, I hope I didn't take up too much time. I had a ton of information to share with everyone. I always appreciate when you guys invite me to share. But if there's any questions whatsoever, please don't hesitate to let me know, or I'll happy to answer anything now if there's still time.
Do we have any questions for the health department?
Have a quick comment follow-up. Thank you, Vince. That was a nice, and it is condensed because they're doing a lot of good work. And I would note Dr. Yazel is also our designee from IDHS on the State Trauma Care Commission. So if you have concerns about that, and on the tracks, we do, and he has said it, I know he probably will later in the meeting, we need EMS involvement. And we have asked our district managers from each of those are sitting in on those tracks. So if you need an EMS contact, reach out to them as well.
Great, thank you.
Any other questions? Hearing none, we'll move on to legislative update. Director Kim.
Main legislative update, we have for IDHS legislation, we're not tackling anything major. In an IDHS cleanup bill, we will be asking for statutory language on the criminal background checks. You will recall this commission has approved a rule and it requires everyone, but it's a nuance with the FBI. They say, oh, that's nice, you do our background check. The state office cannot see the results. The only way they will release the results is if it's a statute. And so we are asking for a statute so that way then we can actually implement that rule more fully. I do want to point out, I haven't heard a lot of EMS heavy legislation. It's not a budget year, so we will not have anything dealing with funding. You've heard redistricting, other challenges. The one thing I think we all have to keep an eye on, and particularly this commission, is that there has been a government reform group that has been looking at the boards and commissions. There are over 250. And when they last did this was when the technical advisory committee was trimmed away. And so they are looking, and I believe they will look at EMS commission. I have not heard anything, I don't know. I think we're one of the higher functioning bodies. But I think we do need to pay attention to what's happening legislatively if a bill is introduced on this. And I think Representative Bartels chairs the committee that we work closely with. And he has said that he kind of wants to hear what the EMS commission does and the fire board, and are there similar duties and such. And so from that end, I think, I just encourage people to be active, pay attention to legislation, because it could directly impact the EMS commission.
Any questions for Director Kennedy? Okay, hearing none, moving on to EMS for Children, Margot Knupfik.
Margot is not here. I have a couple of slides. She will be here. She's on her way. She just could not get here in time for the meeting. She indicated they do have a booth this year, so please stop by downstairs, I guess, from here and grab some pediatric resources. The pre-hospital pediatric readiness reports were released, and they're now going through the data, each of the programs. And so they hope to share probably at an EMS commission meeting, kind of that statewide. I know as our chairperson has indicated, you should have gotten individual results when you actually filled out the survey if you did. The other update is they did host the annual pediatric virtual education. And she noted that, and we ended up with about 70 Indiana providers. And our office, thank you, Corey and his staff, they work on entering everyone so they get credit in ACADIS. I strongly recommend if you need pediatric hours, or even if you don't need hours, you want the education, it's usually very good education. I did do it this year. If you're wondering, that's what it would look like. That's a snippet out of my record. I checked to see it wasn't back there. So thank you, Corey. I did get credit for it. But those were the announcements that Margot had for emergency services for children.
Any questions? Seeing none. Indiana Fire Chiefs Association EMS Division, Chief Sykes.
Good afternoon, everybody. No pressing updates from the association. I wish you all a excellent Crossroads conference and hope everybody learned something. And as we enter this season of the holidays, especially Thanksgiving coming up. Thankful for all you all and everything that you do to help make EMS better in the state of Indiana. That's all.
Thank you very much. Does anyone have any questions for Chief Science? Seeing none, moving to Indiana EMS Association, Nathaniel Metz, or Tom Fenders.
That's just fine. Thank you. As I said, as stated, I am not Nathaniel Metz, I'm Fentress, Vice President. So, first and foremost, I want to welcome you all and thank you all for being part of our conference and being here. Couple things that are coming up, and you may have got an email from me, may not have. Tonight, we have a cocktail hour, networking, kind of revamping of what IAMS does about at 33 Brick Street from 5 to 6:30. If you are interested, please come by. We'd love to have you. Don't forget tomorrow night, if you are at the conference, we have the Roaring 20s mixer. We have a band from 6 to 10 p.m. So please come by, enjoy some drinks, some food, laughter, and so forth. Looking ahead to 2026, I know we're at that time of the year. We have a couple things coming up with Golden Siren and Running with Shears. Both of those will be happening May 16th, 2026, which will be the day on the Saturday prior to EMS week. Why is that important? I'm saying it now is because nominations will open up for Golden Sirens and the other provider awards on January 1. Would love to see, I would love to get our judges to have more work than they want to deal with that many nominations. So please, if you know anybody who is up for Golden Siren, Lifetime Award, or any of the provider awards, please nominate them as we move forward. I think that's all I have for today. Thank you for your time, guys. Appreciate you.
Questions? We will move on. Education Oversight Committee. John Zoll.
Well, commission members, Mr. Chairman, we met a few weeks ago, a really exciting time. We had a fairly good turnout. We met there at Brownsburg. And what we were assigned is from the SIMSCO, their student minimum competency to kind of review. And in reviewing that, we ended up in a lot of deep conversation. And it kind of went in multiple different directions and a lot of different things that we need to look at versus just adopting what their recommendation is or any specific numbers. And one of the, and this is not firm, but one of the things is that we felt that probably a 30 contact minimum for student competencies. And we would also break that down into categories of pediatric and geriatric. So one of the things that we decided is not to submit to you today any formal request for a motion, but we would like to have the opportunity to do more of a deep dive approach, since it did touch on other topics, such as the current psychomotor exam that we're using for the basic life support. It's really outdated. As you know, the National Registry is converting their stuff over more to a psychometric exam, which would be pretty much impossible for us to do, the cost prohibitive, but we need to look at what our requirements are for the state aspect of what we have to do for a psychomotor exam to meet those requirements. And we'd like to incorporate that into one document and then submit that to you at the next commission meeting. We believe we can have that together by then. The other part of that is we'd like to ask permission to continue to meet. I know we usually have it assigned specific, but I think this is going to go a little bit more to where we need to be meeting routinely for a while at least to address some of these topics and make a good decision before we bring it to you for any kind of a final vote. So that's kind of our report for today. I would ask that we get a continuance to work on that or any other assignments that you might give out.
I believe historically that committee works through commission direction, is that correct? Yeah, for commission direction. Yeah, because I'm pretty sure I'm gonna be handing you something here shortly anyway. Thank you for the time being. Let's see. Any questions for Commissioner Zarma? Hearing none. Mobile Integrated Health Committee, Director Kenny.
Usually you can hear me in the back, but I'll make sure we have a microphone because Emily is off today. We extend our condolences. Her grandfather had passed away, and today was the graveside service actually right now. So our thoughts are with her. So I'll be handling mobile integrated healthcare, both the report as well as the recommendations for approval programs. We did meet on Friday, October 10th. We continue to work with our subcommittees. Our next meeting is on Friday, December 12th. We spent a lot of time on data as well and kind of looking at some data solutions. Emily and Corey continue to work on the MIH mapping and the registrations to update those. So if you have not updated your program, you have an approved program, please make sure to get with them. So moving on to our action item, we are requesting approval for several programs. Again, the approval process is there's an application, and then with the advisory committee looks at it, they make a recommendation of approval or non-approval, and then we send it on to this commission for approval. And so they have to include a variety of factors, basically showing they are an EMS provider organization and they're delivering care in their communities. So today we have 3 that we are looking at: Bargersville Community Fire, Decatur Township Fire Department, Marion County, and 3 Rivers Ambulance Authority in Allen County. And I think we have representatives here on some of them. So Bargersville Community Fire Department's in Johnson County, District 5. They list a variety of programs: hospital dismissals, post-response, diabetic counseling and monitoring, chronic disease management, decreased utilization of EMS by high-frequency patients, substance abuse mitigation, mental illness mitigation, OB newborn management programs, elderly management programs, and immunization and vaccination. Broad goals are to incorporate a joint specialized program between the fire department and Johnson Memorial Health. Program will provide broad range of services and will provide seamless patient care from the first encounter throughout in-hospital treatment, as well as transfer to tertiary care, and then finally discharge with in-home care and follow-up. Providers on the training aspect will be required to attend the Johnson County Crisis Intervention Training within 1 year, and then will be required to attend a joint orientation between the fire department and Johnson Memorial Health to cover all aspects, roles, responsibilities, and competencies in hospital and pre-hospital settings. Do we have anyone from Bargersville Community Fire here or online that would like to add anything? The next one we have is Decatur Township Fire Department, located District 5 in Marion County. Post-response follow-up for certain emergencies such as diabetic overdose, diabetic counseling monitoring, decreased utilization of EMS by high-frequency patients, OB newborn management programs, and then utilize Uber Health Transport for alternative transportation methods. Their broad goals of program be focused on high utilizers of 911 system, emergency departments by providing referrals and commercial transportation assistance to community resources to reduce unnecessary ambulance transportation. They will also assist patients with chronic diabetes with the goal of A1C reduction and disease management. For their education, long-term goal is development of comprehensive educational curriculum that can be replicated, delivered to EMS providers, not only at Decatur Township Fire Department, but also those affiliated with other EMS organizations throughout central Indiana that are looking to add MIH programs. I know they were present at our MIH advisory group. Is there anyone from Decatur Township Fire Department in person or online? The final one, Three Rivers Ambulance Authority located in District 3, covering Allen County. They have, their targeted goal are almost all of the items we have available. Hospital dismissal, post-discharge follow-up, and readmission prevention, post-response follow-up for certain emergencies like diabetic or overdose, diabetic counseling and monitoring, chronic disease management, decreased utilization of EMS by high-frequency patients, substance abuse mitigation, mental health mitigation, OB newborn management programs, elderly management programs, including falls, immunization and vaccination initiatives, and then outreach and support for unhoused population. The broad goals are to improve the overall health and wellness of individuals with limited access to traditional health care by bringing care directly to them. This program seeks to educate communities about common health conditions and preventative measures, reduce preventable illnesses, cease avoidable mortality rates, and strengthen long-term connections to healthcare and community resources. Their education will be CPC, CP-C, and pre-hospital trauma life support, pediatric education for pre-hospital professionals, ACLS and AMLS. I believe we had some. Is there anyone from Three Rivers Ambulance Authority that would like to comment in their application? Yeah.
We have a couple representatives here, don't have any comments, maybe, but if you ask any questions.
And they did attend and answered questions for the subcommittee as well. So with that, we are recommending, we took a vote and we are recommending from the MIH committee approval for the 3 programs of Bargersville Community Fire Department, Decatur Township Fire Department, and Three Rivers Ambulance Authority.
Director Kenny,
Yes.
if I could, when it comes time to vote, if I could have an abstaining vote for Bargersville. My employer, Boone County Emergency Medicine, is contracted with Memorial Health in the emergency department, and I have a close relationship with the EMS director, Dr. Barton. So my vote for this would be an abstention for that service only, and the other 2 be.
I will be abstaining from the Three Rivers Ambulance.
Motion to approve. Motion on the table. Second. Okay. Any further discussion?
I would just recommend, and we'll note the 2 we've already heard, but if we do groups like this, we can do them individual. We tend to do groups, but since we do roll call, then if you have a conflict, need to abstain, you can state it at that time, but we'll note the 2 of yours right now.
Any no further discussion? We'll do a roll call vote for all 3, and the abstentions could be noted to the better extent.
Lee Turpin,
Aye.
Darren Hoggett,
Aye.
Dr. Clooney. Aye. Patrick Hutchinson,
Aye.
Matthew Shady,
Aye.
Jerry Carter.
Aye.
John Zartman,
Aye.
Dr. Brown. Aye. Matthew McCullough.
He's falling off.
Okay. Andrew Bowman,
Aye.
Mary Ann Dudley. Aye. Dr. Nassett,
Aye.
Lori Maley. Aye. And Dr. Yates.
Aye. The 3 applicants have been approved. Do you have any further on MIH?
I do not. Thank you.
New business. Proposal on advanced EMT cardiac monitoring, Lee Turpin. This is more of a conversation starter with the intent to hand this to committee. We have for the past several years, especially since ECG monitoring was removed from the advanced EMT curricula, we have had multiple requests to reopen that discussion. There are several themes that occur in that as to why. One of them is recurrent, and that is the fact that we have hospitals that are needing to move patients that the sole reason that they're having a backlog is the fact that the patient is on a cardiac monitor, and the current paramedic shortage sometimes creates delays in that arena. That has been a consistent thread in the requests. And sitting back and looking at this, and they continue to come forward from various entities regarding that particular topic. So in looking at that, I've taken some time and I've looked at the current advanced EMT curricula, of which when we hone in on the medical module of the advanced EMT curricula, it is already extremely short. It is 60 hours. And that's covering all medical emergencies, including cardiac. So that's a relatively short period of time. When we look at the skill base that the advanced EMT currently has, there's some very limited number of medications, IV therapy, IO, some other things. It's not out of the realm of possibility that that is adequate, but at first glance, when looking at it on paper, from an instructional perspective, and I'm sure from others that have worked in the clinical quality assurance realm, you get kind of an initial uneasy feeling with 60 hours there. So if we're going to add in something that is in the realm of ECG transport, ECG recognition, and looking at the way the curricula has been in the past. The curricula in the past was like, you can recognize these ECGs, but you're not allowed to interpret these ECGs. Well, in my mind, that creates a quandary that you're looking at something that you haven't been trained to understand. Or maybe you've accumulated that knowledge on your own and you really know what it is, but you're not allowed by the level of your scope or your certification to say what it is. So it creates quandaries. We've also had in these programs between the intermediate and the advanced EMT cases where this provider is doing this and this provider is doing something totally different. And the possibility of one individual working for both providers and getting confused on the scope of practice between two providers. So this isn't just about the education. This is about the scope, the application of the scope, and the scope of the certification for all individuals that hold that particular cert. So what I'd like to do today is list off some things that in my reading and in my comparisons, I have come to as what I think should be a minimum floor. It is my thoughts and my thoughts only. I don't necessarily have any allegiance to this proposal whatsoever, other than I don't know that it's safe to go below what I've put together. So what I'd like to do is hand this to the education committee and say, here's some framework for you to work around. And you'll come back and say, is that adequate? Come back and say, we're adding to it. Come back and say, we believe you went overboard here, but to get more eyes on it for the goal specifically of allowing for ECG interpretation of both regular ECGs and 12 leads at the advanced EMT level. And I'll deliver this via email to Commissioner Zartman and Director Kinney so that they'll have it, for going forward if they choose to take this on, other than just a cursory look. But the number one thing that I'd like to put forth as tenets on this is if we move forward and do it, all advanced EMTs need to upgrade to it. We really cannot have a piecemeal type situation with a varying scope of practice between individuals. That we would put this in as a mandatory update for all advanced EMTs. I also believe that it should be done by a primary instructor as the primary person taking care of the education, and that it be able to be applied at the provider level and not necessarily create a cost impact by requiring it to be at a training institution. That the medical director be involved, approve the course, the state approve the course, and move forward from there so they can be applied en masse to existing advanced EMTs. Now, when we look at this, again, this is why I envision as a minimum floor. It's up to this committee to come back and say, we think this is a good idea, bad idea, add to it, take away. But we're looking at, as a base floor, 12 hours of ECG interpretation of basic rhythm interpretation, including all rhythms, no exclusions. And that seems to be consistent. I looked at 4 different paramedic curriculums in Indiana, broken down that time frame. 12 hours seems to be about the didactic they spend on that topic. 12 hours additional 12-lead ECG interpretation to include stimming recognition. 10 hours of cardiac anatomy and function. 12 hours of cardiac conditions. And then 12 hours of a lab scenario situations with cardiac treatment and lab scenarios. That on the didactic side comes to 58 hours, 46 of which is didactic, 12 of which is lab. And then additionally, I am hesitant to call this ride along because I think this could be done in a hospital environment as well. So just leaving it in as contacts in general and letting this committee look at it and say, should that be in the field or should this be in an ICU or whatever you could have available? Some people could readily put people into an ICU, others could not. And find that at 30 ECG contacts as a minimum outside the classroom environment. So that with someone looking over them, that they were interpret 30 ECGs on actual patients in a clinical environment. Just throwing that as a minimum floor as a starting point to get this moving. Try to prevent fragmentation as we do it, because I believe that's where a lot of the errors and a lot of the consternation came from in the past, was that I'm allowed to do this at my provider. Why am I not allowed to do this here? Why can't I interpret that rhythm simply because it's not in the scope when it shows up on my ECG monitor? And see if we can't get this moved along a little bit. This does require the creation of curricula. It requires the creation of an approval process for classes and processing them through. So this probably will not be a fast process, but I think it will address that need if we can come to some common ground and consensus on making it able to be moved forward from here. So if you're willing to take that on from the education committee side and put that kind of at the forefront of your agenda and see if we can get some opinions on that and move that forward. Okay. Any thoughts, any comments?
Mr. Chairman,
Go ahead.
I would recommend that in the last couple of years, the evolution of moving away from the STEMI and STEMI paradigm to the OMI or inclusion MI paradigm, that we teach that more broad approach to catch more people who are actually having an acute infarction that may not show the true STEMI changes that we are used to seeing.
Yeah, and I had thought of that terminology as well as I've got a little note here to myself on making sure we train Escarbosa as well. The curricula hasn't caught up to that yet, but that doesn't mean we can't go ahead and stay with that way.
I'm happy to help with that component.
Comment. So I wasn't sure what the chairperson was going to propose today. I do think it is important to look at. I still get, in the past month, I've had a couple of providers, say operationally that the transfers are a challenge. I still believe that when I look at the cardiac monitoring, and maybe this would be more comprehensive. In the past, we've had concerns that it does not clinically improve the outcomes. And in fact, it might be giving an appearance that it could, and in fact, we could be hurting our patients. And I think we have to weigh that in the final result. But if there is a way to do cardiac monitoring that improves operational aspects, then I think it is much needed. I do like the aspect that we want to look at it on our own versus sometimes we're waiting until we get application, usually an annual application from an advanced provider, and then they propose what they want to do. And I think we need to figure out, is there ever an acceptable? Maybe we stick with no, but if there is, what is the standard? And it doesn't matter whose program it is, they have that standard. So from my perspective, I think it makes sense to look at it.
And I do want to make the statement that I do not support my own proposal. So I'm still in the same camp that we have said before, but I want to put something forward that's possible in one resolution.
So you may have explained this and I might have not understood, so I apologize. So an individual advanced EMT would be required to do this, or there would be a drop dead date that if they had not, they would lose their advanced?
That's the way I would look at it to keep us from getting back into a fragmented situation where we had people with various levels of training like we have.
So we're proposing a mandatory, what was that, 60-hour upgrade for all advanced EMTs.
That's the proposal I'm putting on the table to try to solve this problem.
If this proposal is put forward and adopted, is that changing the scope of practice for all advanced levels? And do we have to do a financial feasibility study because that would impact cardiac monitoring on every advanced EMT?
We'll probably correct on that as well. Because you would have to be in advance here prior, have to have a cardiac.
Yep.
No. The question was, would that change require equipment and would it need a cost analysis as well? Which the answer is probably yes. I would assume, and this is one of the assumptions that it's probably a very broad assumption. The providers are requesting to do this today, so, and that's a great point in doing an assessment, so to find out that may not happen. That may be the situation. So.
Mr. Chairman, the only question I would have on that would be glad to take that on, but do you have a dead date, drop date? It just has to be done by, use the mic.
People have a hard time hearing you.
Is there a drop dead date that this needs to be done by or this?
I don't limit. I don't believe we have one. This continues to come up. We deal with it about every third meeting. I just simply want to get something going so that we can either look at it and put it to bed or look at it and solve the perceived problem.
Okay.
I still believe a lot of this comes down to medical necessity and misunderstanding of medical necessity in a lot of cases. And I see your position there agreeing with me on that. So that may be what we come back to and say, this isn't necessary because what we have here is a misinterpretation of medical necessity, which I have at least 50 percentile of me is in that belief field. So, and see what we can do from there.
Yeah, good afternoon. My name is Jeremy Mast. I'm the Chief Operating Officer for Tri-County Ambulance. And I wanted to let everybody know that we support this. Over the last 8 months, we've been doing research on how the advanced curriculum and the scope of practice could help us operationally, as Lee had said. And we've been having numerous meetings. I've been fortunate to get some time with Director Kinney and Dr. Gazel and Dr. English, our medical director, along with Tony Murray and members of leadership of the PFFUI, Chief Andy Meyer, South Bend Fire Department. And of course, I'm not speaking for any of them, although I feel like they were very productive meetings in understanding the advanced and where the scope of practice can go. But I do feel like it's something at this point that instead of, like Lee talked about and Director Kinney talked about, just presenting something different, we would just like to share and show our support for what Lee is asking for. And I'll give you just a quick statistic that we had put into actually a PowerPoint. We pulled some numbers that Tri-County did alone in 2014. So we're located in northern Indiana, so we're talking the South Bend area. Do a lot of transfers down to Indianapolis, and so we pulled those in 2014, and just the ALS calls alone, which equated to a little over 1,400 calls. So that doesn't include ALS calls going to Fort Wayne, Chicago, other areas. This is just coming down here. So you're talking a 2.5 hour, 3 hour one-way transport. That's not going back and all that stuff. So just that alone, 40% of those calls could have gone by the advanced like we is proposing today, which if you read the numbers, that's almost 3,700 hours in which a paramedic would have been available in our region to take care of the critically ill and injured, instead of taking O2 IV minder, sending facility up north down to Indianapolis for continuing care, higher level of care. What is that? So this really does have an impact. It does have an impact on us, and I think a lot of people would just say the same. I think it has a ripple effect through EMS as people are pulled out of one region to transport to other regions. That means somebody's having to fill that void, which means that voids. So it just seems like there's a ripple effect, and adding that advance, adding the ability to help fill some of that, I think would have a huge benefit, probably more than we even realize until we get it there. But I think going back and adding that, especially the cardiology, to the scope of practice would be very beneficial. Thank you.
And
Get the mic for him. He's passing.
Number one, I just admitted that which means looking at this, no secret that I travel all around the state. Pretty ubiquitous everywhere I go. It comes up and it comes up again. And I think that when you hear that in multiple parts of the state, varying services of different structures, I think it's appropriate that we listen and take a deep look at it. I think if there are easy answers, we probably would have figured it out by now. I think they're very valid arguments on both sides of this. From my perspective, as somebody who's worked in a critical access place, I always ask myself the question of, what is the lesser of two challenges? A critical patient staying in a facility that doesn't have the capacity because they're waiting for a paramedic level care, or if you have an advance that can take them in a more timely manner. That's the question I ask myself a lot. I don't know that answer. I don't think it's ever been necessarily parsed out, but I think we need to ask that question as we look at this as well too. And then I have to say, as we do come up with a curriculum, I'm happy to help coordinate that, however need be.
Any other thoughts or comments? At this point, just from chairman's direction, I just push that over to their way to look at, and if they say fit, they can come back to us with a proposal to do something or not. We can revisit it then.
And then we'll have the clinical discussion at that time.
Yes. Yeah. And that's where I think my major headache is the clinical side of it. Not that in any way, not that a person can't be trained from one certification level to do something adequately. It's just looking at what is the actual outcome impact of doing this? Because I think that's where we've always had the deficit, as we have no proof of yay or nay. So.
And my recommendation would be based on some of the other things we've rolled out this year and what we hear from the public is once we get a report back, that it be a report without an action item, say this is the recommendations, we have discussion, and then table it. So that way then, the word spreads and then people that are impacted have more time. Certain things, I don't apologize for because I don't want us to be stagnant and I do push them. But on something like this, I think we would want to allow time for people to understand what's being proposed and get actual comments and allow it to mold how the commission puts it to.
And this will have some magnitude of impact on individuals as well as providers and private instructors and people. So. Okay, no further questions? Sure. Old business, Indiana EMS workforce update. Brittany Dalton from the Bowman Center.
I could start while she makes her way up. She'll probably need a microphone, Jason. That worked right there.
Yeah, there's one back.
There's one.
So the Bowen Center, as you know, we had contracted with them and we heard 2 years ago from Dr. Hannah Maxey. And so we have continued to work with them and then we were coming up with a great update and Brittany is her and her teams who we've been working with, a lot of the same people we knew before. And so we invited her back to give an update on where they are today. So thank you, Dr. Dalton.
Thank you, Craig, and thank you for the invitation to be here. It is my birthday, so I'm just gonna consider this my birthday. Sorry to thank you all for coming today. Friends, are you gonna tell them? Yeah, I'm gonna tell them.
We can sing happy birthday.
Oh, as Director Kenny said, I'm Dr. Brittany Dalton. I am the Assistant Director of the Bowen Center for Health Workforce Research and Policy at Indiana University. And so much great. And we have had the great privilege of with the EMS workforce in Indiana and IDHS. And so my coworkers were here a few years ago to share a few updates. And so I'm back today to just share a little bit more, level set what we've been doing, and then to debut some of our new workforce instruments. So just a quick overview of what I'm going to talk about. I'm going to try to work through this fairly quickly. I'll tell you a little bit more about the Bowen Center, our work and our expertise, what we've been doing as our EMS workforce project activities, and then the outcomes of those projects. So as far as the Bowen Center is concerned, again, some of our big, what we call kind of our big areas are data stewardship, policy expertise, and service and research. So you can see this graphic here, which is really kind of what we're all about. Looking at population health, we want to provide objective data that supports informed policy, that affects healthcare professionals, that again then impact impacts population health. You can see the kind of circular diagram here, which is really what our process looks like. We do a lot of this through our data stewardship work, which we do cradle to grave support for the Indiana State Health Workforce data. So when health professionals go in and they need to renew their license, they do for certain boards that have been put into statute, they do fill out a supplemental survey, which allows us to have more information about the health workforce and the work that they do. We also provide policy expertise. We're a governor-appointed workforce expert on state health initiatives. We do lots of policy analyses, and then we do a lot of service and research work, so program evaluation, workforce assessments, and that has given us the opportunity then to partner with the EMS workforce. So a little bit about what we've done. You'll see a lot of QR codes here, so you're welcome to scan those, pull those up on your phone. So we started this in 2023, and this evaluation included 4 parts. So we've got our sustainable workforce tracking. So this is our development of the supplemental questions that would be embedded in the license certification renewal system that would be used for longitudinal support of the reporting. The EMS workforce needs assessment, so a county level evaluation of supply and demand, looking at the pipeline, so examining the EMS training infrastructure in Indiana through data collection from instructors and students, and then a retention assessment, understanding the factors that impact retention of training and loss of existing EMS professionals. So this led us to our training program evaluation, where we're looking at those educational programs. So the first part of this is an evaluation of student perspectives, and we call this our kind of pulse check surveys. This is where we ask students to kind of provide a little bit more of their perspective about their training. So this survey was actually implemented in the ACADIS system, and it's targeted towards students that have recently completed their training program. So we use REDCap, so ACADIS will send them into REDCap, and then the data are exported quarterly, and we format it for quarterly reports. So these topics include demographics, their training characteristics, their skill readiness, and their employment plans and desire. Again, this is all self-report from the students, typically as they're finishing their coursework. The second part of what we've been doing is our sustainable EMS workforce tracking. So this is just our regular data collection. This is the supplemental data collection that, again, is implemented in the ACADIS system during license renewal. So the questions cover demographics, training, employment status and plans, primary and secondary employment characteristics. And you can see the sources we use for that survey development, the Indiana minimum data set. You can see the NAEMT 2022 report, NREMT 2004 to 2008 core survey, and a workforce profile survey. So those survey data are also collected using REDCap, and those data are exported annually and merged to our administrative license data for reporting and visualizations. So this is just a little bit of a representation of how we kind of move through this process. So you can see that all the way there on my left, the REDCap system, the ACADIS system, how we look at data collection. We move those, merge those into one file then to clean and code that data. We manage the data, develop dashboards, and then report on that data. So that is kind of our technical assistance, technical process for how we get from data collection to what I get to share with you today. So I just want to look at a few quick project outcomes of kind of what we've been able to see from, we are actually finalizing these deliverables, and we will be delivering those to the IDHS team at the end of this year. So actually they'll have those in a few weeks. They'll be able to provide feedback on those, and those will be finalized by the end of 2025. So first, starting with that student pulse check survey, you can see these are just 2 pieces of those results right here. So on my left there, total student survey respondents by quarter. So you can see that we increased student engagement over time. So we were able to work closely with Craig and his team to determine what was going on when we saw that 8, what can we do? And so we were able to work closely with them to create solutions that allow us to then, you can see, increase that student engagement over time so that we can get results from more of those individuals that were finishing changing their programs of study. And then you can see the gender distribution by quarter. So this is just broken out by male, female, prefer not to say. This is also just a look at the demographics of the students that completed the pulse check survey. So you can see the percent of students in different EMS programs here. So EMR, EMT, AEMT, and paramedics. So you can see the majority of the EMS students that responded to the survey were enrolled in an EMT program. And from July to November of 2024, you can see the majority of EMS students were in the paramedic training program. So this question asked the students about what calls they were most comfortable with. So essentially it says I'm very comfortable with, and then provides different types of calls that they could potentially respond to. And we broke these out into two different graphs just so there weren't 20 lines that were all overlapping one another and making that very difficult to see. So you can see on the left and the right, the different lines there. So some key points here. Most EMS students reported that they were very comfortable responding to accidents. And then you can see there on my right, very few EMS students reported that they were comfortable with responding to a call that was about the death of a child. So I think this is a really important discussion, a really important kind of point of data to look at.
You have reached the Washington County Auditor's Office. Our hours are 8 to 4, Monday through Friday. Please listen carefully for the following extensions. Press 1 for
trauma and some of the wellness initiatives around people who respond to trauma. When we look at the different types of calls that individuals may or may not be called to respond to, and we see what they're comfortable versus what they are very uncomfortable with. So the second portion of this is the sustainable workforce reporting. So this is a big part of what we do at the Bowen Center in terms of being able to actually have a sustainable format to provide more information about different health professions workforce. So today I have the great pleasure of I'm really going to talk this up. We're going to debut some data dashboards to you that are filterable that allow you to look specifically at different data points that can help answer specific questions that the commission may have and that other individuals may have. So it's been very interesting for me to hear some of your conversations and know that we have some resources that I think are extremely helpful as you're having conversations about different needs and how you can best serve populations. So to intro the dashboards, just starting by telling you that they are filterable, so you can go in and you can look at renewal year, you can look at license type. So all of those are, all the different license types are in that second drop-down box. Primary focus, their EMS role. So you can select all of these different pieces. You can filter it to look at exactly what you're interested in looking at. So I have just selected a few of these dashboards today, just to go over them with you. At the end of my presentation, I've got different QR codes that take you directly to all of those. These are publicly available right now, even though they are not, we're not 100% finalized with approval, but they are publicly available to those that have the link. So I've got those QR codes in here. So I can't filter from where we are, but if you go to those dashboards, you can play around with those and have as much fun as you would like to with those. So they start with a cover page. So you can see here, this is just a general overview of the EMS workforce, supply and demand, and licensing trends. So here you can see how many EMS licenses and certifications have been renewed each year. This is a collaborative effort that started in September of 2023. So our numbers do not necessarily represent all licenses or certifications renewed in the year, but the cover page here is going to provide a summary of the workforce along with the workforce statistics that are provided by the Bureau of Labor Statistics. So you can see the mean wage, anticipated job growth. Those are both from our Bureau of Labor Statistics. And then you can see that the actual total certification renewals by year and the actively practicing EMS professionals are from the actual data collection. Yes.
What classification is an ambulance driver? Yeah.
Well, that's a great question. That I guess is just one that we have listed there, under their classifications, but if that is not something that is necessary, or if it doesn't make sense, then we can reclass that.
No, we have people that are just certified to drive an ambulance that are non-EMTs,
We still have ambulances in state.
believe it or not.
And I think where some of this comes in, if I remember right on the data, some of this too is coming from the student surveys. So a lot of times these are EMT students that identify as an ambulance driver because they aren't certified yet, so they have to identify.
So this is actually, this, where the ambulance drivers are, on the right here are gonna be from the Bureau of Labor Statistics, but now if we're looking at the left, then that's actually, that certification, the renewal data. So that's actual data that's being collected.
I questioned the same thing, Commissioner Hoggett, not too long ago, because I saw an ad for ambulance drivers. I actually kind of queried it and said, what does this job entail? And it is literally a trained non-EMT guy, so.
So that is relevant and that is
Yes.
appropriate. Okay.
Some providers are still utilizing.
So that is the other caveat that I will give you. I am the data and the health workforce expert. You are the EMT expert. So I will listen to you on what you think is relevant versus not relevant. So the next dashboard is our education and training dashboard. So this displays where EMS professionals complete their training and education, their highest education, and plans for further training. So again, you can see on the left here, that's where you can filter all of this data. So the whole goal here is to see where we're growing our own EMS workforce. So this is actually really great news. You can see that in terms of our workforce, 94% of them are actually trained in Indiana. So this is a great thing for our local workforce development. We are growing our own and they're staying and they're actually actively practicing in Indiana, which is better than our contiguous states. You can see that reported highest education level here. So you can see the education that EMS professionals are obtaining beyond their required training as well. And any education plan that they have for the future. So just for an example, if we were going to play around with this, if I just selected EMTs, then looking at the reported highest education, again, this is looking at every single one that's included in the dashboard. But if I were to filter that to just EMTs, 886 of them report a bachelor's degree, their highest level of education. So that would be 17% of them. 32% of them completed their highest education through a fire department, while 20% got their education through community college or college and university. So it allows us to look at where they're getting other training, have they received other training, do they have future plans for other education? So again, this can help us understand, help the state understand how many EMS workforce members have education outside their workforce training, again, where they're receiving that. And so again, helping us understand who these individuals are, how they've been trained, and what their education path has looked like. And next piece is looking at employment characteristics. So this dashboard is a summary of current practice information, shift characteristics, and their employment plans. This helps us look at where EMS professionals report their focus of primary employment. What employment plans do they have? How many of them plan to retire, for example, versus how many of them want to increase their hours? We've got a cross tab here of reported downtime and reported longest shift, which helps us look at well-being. So again, if I were to filter this data, I would see that 77.62% of EMTs report 911 responses as their primary role. So responding to those 911 calls. And that is relatively similar for those that are paramedics, which is 76.11% of paramedics report 911 responses as their primary role. And in both of those categories, they plan to stay as they are, so they don't plan to make any change to their role as it is, not to increase, decrease hours, or to retire. If I turn that to looking at advanced EMTs, then that's gonna show me that 88% of them say that their primary role is to respond to 911 calls. So you can see those other, focus of employment there. Specialty EMS services, EMS administration, interfacility transport. And then last, we have geographic supply. So this is a summary of EMS professionals covering different counties in Indiana and the level of care that's provided. So this allows us to see a graphic of how many EMS professionals cover each Indiana county. So we can identify communities that could use additional support or that don't have enough supply for the demand. Allows us to see how many EMS professionals have to respond in each county, their average number of calls. So are those average number of calls too high for a county? Should they be higher? A distribution of EMS professionals in each county, and then allow us to look at if there's any counties where EMS professionals are working long shifts more often than other counties. So just for an example, again here, if I were to filter this data to look at Marion County only, I could see that there are 500 EMTs that are included in this renewal sample. 39.59% of them say they respond to 6 to 11 calls for each shift. 309 of those are EMTs, and they report, 42% of them report 12 hours as their longest shift. If I then select Washington County as a comparison, I can see that there's 20 professionals. They respond typically to 1 to 5 calls during a shift. But most often, they are at 56% working 24-hour shifts, is what they report. So it allows me to drill down that data into those counties, so I can again see how many do we have, what's the supply and demand here, what's their longest consecutive shifts, how many calls are they responding to. So these are all the QR codes to those different dashboards, so the cover page, and Director King, I assume that they will have access to these slides, and we can also get the commission direct access to the dashboards through the links that take you directly there, if you would like that as well, so that you can go in there and you can also provide feedback as we're finalizing these. But the whole goal here is that you can have this access to this data. This is publicly available data that you can actually go in and filter based on what you're looking for, what your needs are, help you actually answer questions about the workforce, the population, different needs, different shortages, and essentially how we can best train and support both EMS professionals, but also the populations that they serve. So again, thank you so much for the invitation to share this with you. Again, we can get you access to those dashboards so you can look at those, you can provide any feedback and any information. But the Bowick Center is very privileged to be able to partner with IDHS on this work. And it was a pleasure to get to share this with you today. Does anybody have any questions that I can answer? I know that's a lot of data in a very short amount of time, but I'm glad to answer any questions.
That's stellar work. That's
Great.
great.
Thank you so much. Thank you. And I really appreciate Dr. Kenny and his team because they are our right hand in this, and they've been extremely helpful in just making sure that we have what we need to do this work. Yes.
If we just go to the bowenportal.org site, will that allow us access to those dashboards?
So not yet, it will. Once we have the dashboards, once we get permission from Dr. Kenny and his team, those will be publicly available on the portal. Right now, we still have them in like a sandbox format for us, but again, we can send those to you so that you have access to them outside of the portal. But after December 31st, those will be available on the Bowen portal.
Thank you very much.
Happy birthday.
Happy birthday.
Thank you so much. Thank you. My shameless plug for the day.
Next, moving on, old business diversion statement, Commissioner.
Thank you. So as many of you will recall at our July meeting, brought up the initial discussion proposal on resolution on EMS diversion. This was originally created by Dr. John Schmitz, who's an EMS medical director out of Hendricks County and a member of the Indiana National Association of EMS Physicians, or NAEMSP, of which I'm the secretary. So a little conflict here with the commission with that. But the initial proposal is basically looking at prohibiting or reducing diversion of EMS away from hospitals, emergency departments, because of census in the hospital or the emergency department at any given time. And this went through a couple iterations from his original proposal. His most recent one was in September. But the one we're looking at today was Dr. Schmitz and Dr. Caleb Care Sites took this to the Indiana State Medical Association as a resolution that was reviewed and adopted by the Indiana State Medical Association. And that's the proposal I'm hoping to bring to you today for your approval as an EMS commission. So just a few highlights. That top paragraph, EMS diversion may be utilized for special care needs and disaster type situation that really shows that critical power, equipment shortage, or security risk, but that EMS diversion is ineffective as an emergency department crowding management tool, and it basically ends up in a domino effect to other hospitals within or outside of that original counties where the EMS was going. They note that EMS diversion results in decreased EMS system performance, longer transport times, reducing availability of EMS in the host county that they're being diverted from, oversaturation of patients to the neighboring emergency departments in same or other counties, restricts the patient's right to choose where they go, which might also impact them financially, as that hospital they're being diverted to is not covered by their insurance network, so they face a financial cost. And there's patient safety risks that are thought about where patients told, hey, we can't take you to this hospital where you want to go because they're on diversion. The patient said, well, I'll just not go by EMS and drive myself. It has a critical event that could have been treated by EMS. And so the patient has a bad outcome. And so the resolutions, which are on the second page, let me go down to that. So Indiana State Medical Association supports accountability and transparency regarding hospital-initiated EMS diversion at the state level. And basically working with Indiana Hospital Association, Department of Homeland Security, EMS agencies, Indiana Department of Health, and other stakeholders to establish clear, enforceable statewide guidelines limiting hospital-initiated EMS diversion in Indiana, except to include narrowly defined circumstances such as disasters, critical equipment failures, or special care needs, with provisions for oversight and regular review to ensure patient safety and compliance. That IMSA will collaborate with different organizations to monitor and send out to the public those diversion instances, how long they're on diversion, for what reasons. And that finally, EMS agencies should recognize that the diversion request shall be reviewed as a request only and can be declined by the EMS agency. Are there any questions? So I would move that we adopt this resolution as approval by EMS Commission today.
Second. We have a motion and a second. Do we have any further discussion? Hearing none. All the roll call vote.
Lee Turbin,
Aye.
Gary Hoggett,
Aye.
Dr. Clooney. Aye. Patrick Hutchinson.
Aye.
Matthew Shady,
Aye.
Jerry Carter.
Aye.
John Zartman,
Aye.
Dr. Brown.
I'm in favor with the caveat that I also have a conflict as the board chair for ISNM.
Matthew McCullough,
Aye.
Andrew Bowman,
Aye.
Marianne Dudley. Aye. Dr. Nosset,
Aye.
Lori Bailey.
Aye.
Dr. Yezel.
Motion passes.
Thank you.
I think that's great.
That's a
That's awesome.
Okay, moving on to the third item under old business, advanced EMT scope of practice, life game for use during IO initiation. Dr. Yu.
If you may remember from the last council meeting, somebody brought up that question of is lidocaine for the purpose of pain control for administration during an IO, for instance, if that has been approved. We discussed it and there was some thought that maybe we had addressed that at prior commissions. I think Director Kenny and some other of us took a deep dive and could not find any definitive statement along those lines. So I think that, at least from my personal opinion, I do think that's something that I would be in favor of approving. I think there's two kind of scenarios we could look at. Number one, the idea that that is an inherent part of that procedure. And so by approving that at the advanced level, it's kind of tacitly approved as well. The second one is to specifically approve lidocaine for that purpose. I honestly am in favor of number two. I'm not a one that likes to quibble over minutia, but I think for two reasons. Number one, 5 years from now, I can see it coming up again and us saying, did we talk about this, and having to dig through commission meetings again and kind of review that purpose. And number two, I think things get misconstrued, and I can see this as a lidocaine's been approved at the advanced level and, in the cardiac active form. And I think so probably an actual approval specifically stating the purpose is the safer and smarter way to go here. So that would be my recommendation, but certainly up for any kind of discussion.
Pleasure of the commission.
Motion to approve lidocaine for the use of IO initiation.
Second.
Motion and seconded. Any further discussion?
Only question would be a clarification, and as I'm envisioning it, and I know Dr. Yezel's planning to work, if we get a new web designer at IDHS on it'll look a little similar to the current grid, but more user friendly. So I'm assuming this would go where it says, with the IO, it would say, and be listed there with the IO. And that way there wouldn't be confusion as an approved medication in the medication section.
That probably should have added in. Yeah, we are looking at revamping that. We're getting enough caveats to that scope document that I think it's starting to create some confusion. There's enough sidebars that we need to look at adjusting that format a little bit to make it more user friendly. And I think this would be one of those that would be ready made for that.
Yeah, I think I'm fine either way, but I think you could argue that maybe you should put it under the medicines and say only for items and not for, dosing for, because it's really not just the IO route either. It's going to be used at the dose for
The specific purpose of pain from
IO surgery.
Yeah, we can do that.
I support this greatly, although when I read this on my agenda, I did just some quick research, and there was a recent study looking at the use of IO lidocaine for the treatment of pain of use of the IO site. And basically, the authors acknowledge it's unclear if lidocaine administration after IO access actually decreases pain significantly or not. However, they feel that since it takes little time, may help, and it's unlikely to cause harm, they support its use. So just some research to help support that.
And I'll add before we vote that this is a great example of looking at the evidence-based medicine involved, because as we were talking about this, some of the first thought that came through my head is it's essentially, having seen it done both ways, this is essentially a human suffering issue, and honestly, how we missed that. I think we all assumed that came with it, but we just didn't specify it enough. So that's a prime example of doing a scope change for the purpose of correcting something that was probably done incorrectly in the first place. Yeah, again, excellent work.
Right.
Any further discussion? Let's call roll call.
Lee Turbin,
Aye.
Darren Hoggett,
Aye.
Dr. Clooney. Aye. Patrick Hutchinson,
Aye.
Matthew Shady,
Aye.
Jerry Harder,
Aye.
John Zartman,
Aye.
Dr. Brown. Aye. Matthew McCullough,
Aye.
Andrew Bowman,
Aye.
Marianne Dudley. Aye. Dr. Nauset,
Aye.
Lori Bailey,
Aye.
and Dr. Yeaple.
Aye.
Pass.
It's pretty good.
Let's see, moving on to administrative proceedings, waivers.
You have the waiver orders in front of you. I don't have any to highlight. When you get to the sanctions under the personnel, we have two that I flagged. We do have one revocation. That's an individual that was convicted of voyeurism using a camera. And we issued a revocation, did not feel that was appropriate to have that active license within EMS. The second one was Kaiser Ward Fire Department, not trying to embarrass them. They did have reasons why they didn't get it done, but they renewed on October 3rd after an October 1st expiration. And if you recall, we set up a sanctions table for organizations because the rules say they have to do it 60 days in advance. So depending on how late in the 60 days, and in this one, they actually had 2 days that they frankly probably operated in which they were expired. So we did issue a sanction censure with a fine. I think the reason that I'm bringing it up, again, not to flag that department, but to say it is a reminder to all provider organizations and training institutions, there's a 60-day cutoff that you are supposed to renew before your 60-day expiration. That's because our staff has to have time to go through that and check the factors, and sometimes there are corrections, and then you get renewed in time. If you're an organization too, once you expire, CMS and your billing agents are going to start calling you and saying, where is your new renewal? So you do not want to do that the last week. So again, renew 60 days in advance if you're an organization. Those are what I had for that. On the rulemaking, no updates there. Appeals docket, nothing to flag there. The Keener Township, we had several respondents, and council and I are working on a agreed disposition of those.
Questions? We'll move on to staff reports. Data registry, Rob.
For all of the fire departments, you should have gotten a email from Nearest to onboard your fire department. I just got an email about an hour ago from Nearest. We have 66 departments with nobody, no account yet. So I'm gonna work on getting the right contact person for those 66, get that back up to Nearest to do that. I will say, for anybody that's using the state image trend system, I need to get you a client ID number to put into that when you onboard. I've been sending that out. This has taken up probably 80% of my time right now is talking with fire departments. We also had an upgrade to image trend that took 3 weeks to get it done because they kept throwing errors. Finally, also about 2 hours ago, I finally got word the report writer is back up and running. So you will see later on, I have no numbers because the report writer has not been working, so we can't run reports. But that apparently is done now. So anybody that is using the state image trend system, you'll have a client ID. If you're using First View, ESO, any of those other ones, they should have given you their client ID number to put into that system. Anybody got any questions on that? And I'm still learning all of that also, but I'm talking with Nearest back and forth multiple times a day. I will also say for the fire and EMS side, we've gotten approval to hire the EMS and fire data manager. I've gotten the job description done for that, so I will be getting that into the state system. So if anybody knows of somebody that would like to become our fire and EMS data manager, please, we'll be getting that out. So if anybody has any questions,
please email any of the field staff or anybody, and we will get you that information if you can't find it on the state website. But once we get it on there, we'll be sending it out to everyone. For the EMS side, we are at 3.5.0. We will be working towards 3.5.1 soon. I don't have a date on that, but we will be working on that. The data managers from the SIMSO met yesterday. There's still some discussions on a couple data elements that will probably actually even have to be in the next version. But just trying to figure some of those things out for different data elements. Of course, I don't have any numbers because the report writer wouldn't work. This is just numbers that we have right now. I will go back to Director Kinney's statement about organizations and your renewal application. I would say probably 80% of the provider organizations, training institutions, supervising hospitals, that applicant or that certification is in ACADIS. If you have an email for the organization in there, you will get the reminder email 90 days prior that you need to do that application. So please make sure that you've got an email address under the contact info in ACADIS for the organization, and you will get that email. Just like any other people certification, it comes out 90 days prior. So if you don't have access to that and need access to your organization, get with your district manager. We will get that to you. But I would say we're about the 80% mark of having all certifications in there. So if you don't have it in there yet, you don't have access, please ask your district manager and we'll get that taken care of. That's all I have, unless somebody has questions.
Certifications and compliance report. Go ahead.
Currently our certification numbers are up still. This is from the third quarter of 25. We're still last commission meeting, third quarter. The third quarter is a good report, accurate for them. As you see, they're still up. Some individuals did not want to renew their certification. They renewed late. 35% EMR, 23% EMTs, 12% of advanced EMTs, and 10% of paramedics, and 17% of primary instructors. Total, we're over 26,000 EMS providers in the state. We're up 627 from the second quarter of 25. Audits, third quarter we did 212. 16 of the audits they didn't respond to them, about 80% of the total. There was 6 sanctions issued for their renewals. That would criminals. 69 individuals indicated a criminal record. 5 notified us that they were arrested within the third quarter. Those are pending work. 44 were cleared. 9 were waiting for more information. 11 we have in for the system, and we have 0 good. PSID applications, they are taking about 24 to 48 hours to be turned around, along with certifications applications. We're asking that individuals that are applying for PSID numbers complete the application, not the organization individual. So the person that's applying for a PSID number needs to be the one completing the PSID application, not someone else. The same thing goes for the reciprocity application. It needs to be the person that's applying for an Indiana certification license, not someone from that organization. And again, the certification turnaround time is still about 24 hours. Guys, for everyone gets everything done the first time. Questions?
Okay. EMS education and training report. Sherry.
actually be me. Carrie is, we are sponsoring, co-sponsoring. We were fortunate to have National Registry of EMTs came and did a nice workshop for our instructors, and we have 3 instructors there. So that would have been nicer to have more people turn out. But Carrie is over there doing a state update following the National Registry portion. So I will be delivering our updates. The primary instructor mandatory training, as you recall, we modified that slightly. We had the in-person offerings, and then we have the course that they would then take if they did not. So here are the mandatory primary instructors and the attendance there. We have 12 different offerings, and you can see the different attendance that we had for each one. And then basically we are down to 267 instructors, and that is decreasing as word is getting out. We are looking at, there's a little bit of a hiccup. A couple of people had problems with taking the online course. So we're looking at that. But they were supposed to complete a course by January 1st. If they do not complete the online, then what the commission had approved was we are not going to revoke their cert or anything, but they aren't eligible to actively teach in a program until they take the course. And it should just be a few hours. It does have a quiz that goes along with it. And so we did email everyone who was not in compliance with instructions on how to do it. So everything is progressing on the mandatory PI forum. Carrie wanted to let everyone know there is one more PI quarterly update. That'll be the December one. We have Tuesday, December 9th for a morning session, and then a early evening on Wednesday, December 10th. And then there will be a guest speaker talking about the use of AI in the classroom setting. So with that, unless there are questions, that's all I have on the education update.
Okay. Before we move into the final report for the state EMS director, director, and chairman, I do have a request to speak to the commission. If Meredith Addison want to come forward.
Thank you for allowing me to come speak. Meredith Addison, most people just know me as Mary. I am now retired, and I don't want to use the B-O-R-E-D word, but if there's anything I can do to help recruit, I can go places, I can talk to whoever you want. Anytime anybody at a state level says we need to move upstream, I automatically think emergency medical services. And when they talk about millions and hundreds of millions of dollars in rural anything, I automatically think that turnaround time equals EMS. So if there's anything I can do to help, please let me know. And I'm back in the back knitting and trying to keep my mouth shut.
Thank you.
Good luck.
Moving ahead, state EMS director's report, Director Kent.
Couple announcements from the agency. As you heard last time, Jonathan Witham is our agency director. He made a couple announcements yesterday. Justin Goodell, who you may have known as our general counsel, was designated as the chief of staff over operations. And so he will be over EMS, response and recovery, and then the fire, and then the planning and building code and all that. So congratulations to him. And then a familiar face sitting down to our right is Sean Whitting, has been our deputy general counsel, and he will now be general counsel for the Indiana Department of Homeland Security. We are here at Crossroads. We intend to have most of our staff here. And so we are a sponsor, and you will find us at the booth downstairs in the appropriately named Robert Miller Exhibit Hall. And then our new driving simulator is this 2 rooms down, and that will be available. You may say, I've seen the driving simulator. There is an IDHS Fire Academy one that is more tailored for fire response. And we were getting a ton of requests from EMS organizations. And so this is something that we have added to the fleet, is the mobile driving simulator, and it is simulating ambulance driving. The other one had one ambulance program, I believe, on the regular driving the fire academy has, but this one is dedicated to ambulance scenarios. And so encourage you to pop in and say hi to us at both locations. We will be glad to see you there. As always, I remind people, I just like to make it clear, one way to get updates is, and if you have updates, feel free to submit. Corey Wells coordinates, but we have the EMS Dispatch, which is our newsletter. We had heard last time from the NDOT on the traffic information responder program and the TIM program. And with that, it is coming up, and it is actually, I apologize, it's not coming up. It is Crash Responder Safety Week. And so there are resources out there, and I just wanted to flag that, and that's their website if you'd like to use some of their resources for Crash Responder Safety Week. Thank you. Everyone's doing a good job of taking those training. I am not very occasionally, I would say 1 in 20 people tell me of all the things we have to take training on, why do I care about highway and highway safety? It's not going to happen to me. And I think everyone else has been supportive that it's a well put together training program. So I'm glad that we are offering that. You did hear reference earlier. We did have strong EMS participation, saw many people there that were involved with statewide trauma and emergency medicine symposium. Picture there, Dr. Yazel and I co-presented for the first time, and that was kind of fun. I encourage people to watch those, and again, have EMS participation in the track and in the symposium. On to Health First, EMS readiness. We are in our 3rd year of it, and it is fiscal year 26. And a couple of the projects I want to highlight. We did do the Mobile Integrated Healthcare IDHS EMS Companion Grant. If you'll recall, typically the MIH grant we do through the commission, and you approve the programs based upon our recommendation. That grant was not funded. That's a statutory grant. And so we issued money. We were eligible to do it out of EMS readiness. So we did that. And so we, as an agency, approved the application versus differentiating it from the one that exists in statute for the commission. So I didn't want you to think that we were bypassing commission. It just made it a more efficient process. And we were able to, one, get the applications, process them, and get the notifications. I'm excited to announce we have committed to 500,000, and they were digging in my pockets on readiness. So we ended up going 591,000 because there were good programs, 18 total programs. New programs were 8, expansion 10, and new eligibility were 7 counties and 2 hospitals. And we followed the new statutory guidelines that said as long as you're an EMS provider organization, you can do it. Sadly, we did not award 11 programs. Most of the 11 programs, I think 1 or 2, we did not find technically eligible. The rest of them were programs we have funded previously out of the EMS Commission Grant Fund. And because the budget was tight, we said, unfortunately, because you have received in a previous year or the year before that, then we kind of said, no, we're not going to do this year for your expansion. So apologies to those programs. There just was not enough funding to go around. There's a list of the providers. We did go ahead, I authorized, we have published the list, handouts available, and we can submit that to the commission. It has a good description of what people are doing, what we have rewarded, and that sort of information, because I know it's a little hard to read. Actually, it's not as bad as I thought it'd be. We have a nice huge screen. But we did look at every area of the state, had a lot of great applications, and I feel like we're going to do a lot of good there. The other EMS readiness one we have is the AED grant. We offered AEDs available through a state vendor. So essentially they offer a variety of AEDs, and there's a catalog. And then if you applied to us, we'd authorize you to purchase, we pay the bill. So it made it pretty seamless. Honestly, we did a 1-month program. And the enrollment was less than what we had hoped, less than 100 organizations. And so we have roughly, if you look at BLS non-transport, correct me if I'm wrong, I used to say about 400, 500. And so with 500 organizations, we didn't even reach a fifth. So we reopened it. It's open right now. So if you know a BLS non-transport, encourage them to consider applying for that grant program. EMAS Compact update. The main thing we did there, we had a full commission meeting that I presided over, and we adopted new rules, which will be nice to protect. It basically says if you have someone that you have sanctioned or reviewed for a criminal conviction, even if you clear them, you should mark their privilege to practice in the NIPSCID database as provisional, so that way then the receiving state can make that determination whether to agree with our judgment. So let's say we went in and said, we are going to certify you, it's possession of marijuana 10 years ago. Indiana, we don't care, we're going to move on, it wasn't work related. Another state might say, no, we don't ever allow a marijuana user, we're going to disqualify them. That's their choice if they do it. Conversely, though, let's say they have something they don't consider serious, like the voyeurism charge, if they did not, we might review it and say that's incompatible, and we do not grant your provisional privilege practice. So I think this will protect all the states in the compact and is a positive improvement. NASIMSO, we still continue to work there. I don't have a lot of updates, so I'll move on. EMS World Expo was in Indianapolis this year. Very successful last month. Some pictures from our booth, and then I was privileged to do a welcome to Indiana announcement. Was exciting to have. I've not heard the final numbers. They were thinking between 6,500 to 7,000 people. And so it was overall reviewed very well. The boots on the ground really appreciated it. I'm still hearing a lot of positive about it in Indianapolis. So hopefully we'll host again in a future year. They also did the MIH Summit with NAMI-HP, who is a national organization of mobile integrated health providers. We are a state member, and several of our MIH providers are there. They were present. I was privileged to participate in the panel discussion. I think Dr. Yazel also was involved in one of the panels or a presentation because he's a board member at NAMI-HP, but we were happy to have them there. The last thing I have is just a reminder of our dates. We did correct one of them that Commissioner Bowman caught, but these are the dates that we have next year, and Emily did send those out. If you are a commission member and did not receive them, please let us know, and we'll make sure that you get those so that you have the dates for next year. I do not have a slide for it, but reminded me earlier, first of all, happy birthday to Brittany. We appreciate her with that. And we would also, I think it's appropriate time of year, wish everyone happy holidays, including Thanksgiving, Christmas, whatever holidays that you celebrate, because our next meeting is not until January. That is all I have, but I'm open to any questions on my updates.
Any questions for Director Kent? Hearing none. State Medical Director's report, Dr. Gason.
Just a couple of brief things. Number one, I want to thank the EMS Association for putting this together. The growth over the last few years has been awesome, and I know it's a lot of hard work. And also be remiss if I didn't mention Bob Miller. This is his heart and soul into it, and he'll be missed. So just thanks for all that you've done to put this together. A couple things just to kind of double down on what Vince said as far as the Rural Health Transformation Act. It couldn't be more important that we stay involved in this. For once, we have funding to do a lot of the things that we wanted to do for a long time, and EMS is prioritized in that funding, and we just haven't seen that in years. And I think it's between getting to the track meetings, the regional advisory councils, and then one portion of that Rural Health Transformation Act that he mentioned, the regional coalitions. So in the Department of Health preparedness districts, those are coalitions, and it's going to include EMS, local hospitals, health departments, multi-counties going in as a group and saying, these are what we need as a county. And a lion's share of that funding is going to go out to that model. And so we do need to make sure that we are integral parts of those coalitions to make sure that things move in the way that we'd like to see them. The Regional Medical Operations Center model that Vince mentioned as well. You know, we typically talk about it in terms of interfacility transfers, but actually one thing that Texas has done very successfully is help with navigation of mid to low acuity behavioral health patients. And Indiana will also implement that model in phase 2 of the Regional Medical Operations Center model. So you'll get some assisted navigation of patients, whether it be communication with your mobile crisis teams, direct transport to behavioral health facilities or crisis stabilization units, things like that. So look forward to kind of collaborating with everybody as we get that phase of the Regional Medical Operations Centers going as well. Last but not least, and I am no expert on federal legislation, but this week the Comprehensive Alternative Response to Emergencies Act was brought up. And basically that's a 5-year treatment place model where Medicaid would reimburse essentially for treat no transport. And this is a big deal. I think it's really important that, you know, number one, we watch the verbiage to make sure it's impactful as we feel like it can be. And, you know, this is a pathway to sustainability for some of our MIH programs and alternative destinations and things like that. So if we could see this move forward, I also think that's a very important one for EMS. So any of you that have federal contacts, please reach out and make sure that we're in the loop in those kind of discussions, and we'll keep updating as it moves forward, hopefully as well. So, and that's all I have.
Any questions for Dr. Yancey? Okay. Chairman's report direction. The only thing that I have is registration's open for National Association of EMS Physicians meeting. I believe that's Tampa this year, second or third week of January. Go for the breaking science and especially the abstracts. So it's a good conference to go to learn the future on the clinical side of EMS. That said, move on to next meeting. Next meeting is January 9th, 2026 at Made in Plainfield. And with that, we are at the end of the agenda and I will accept a motion to adjourn.
So moved.